The program is SPARK. SPARK is a program brought to you by the International Center for Investigative Reporting, supported by the International Budget Partnership (IBP), to tackle pressing issues in our nation around unequal maternal health care services, gender-inclusive agricultural support for small-scale women farmers, access to loans, among others. I'm your host, Blessing Ebireri. The Midwife Service Scheme, MSS, a Nigerian government initiative launched in 2009 to tackle high maternal and child mortality by deploying skilled midwives to rural primary health care centers, PHCs. Its goals were to increase skilled birth attendants and reduce deaths, achieving some success in increasing deliveries, but facing challenges. Joining me now to share expertise on our topic, examining the impact of the Midwife Service Scheme, is Jama Medan, the chairman of the National Association of Nigerian Nurses and Midwives, FCT Council, and Chinyere Uzuama, Deputy Director, Nursing Safe Motherhood Coordinator. You're welcome to the program.
Thank you.
Thank you.
And to your esteemed listener, the telephone line to make your contributions are 0808 828 144453 or 0915 091 0483. You can send your questions on WhatsApp to 0810 250 7579. I'll take that again, 0810 250 7579. We are also live on Facebook at the ICIR. Don't forget to include your name and location. Let's dive into what we have for today. I'll be starting with you, Oka Madan, as the chairman of the National Association Nigerian Nurses and Midwives. Can you tell us the positive changes you've observed in maternal and child health services since the introduction of this midwife service scheme?
Thank you very much, Blessing. Thank you, listeners. Like you said earlier, this is a program that was introduced in 2009.
Yes.
And actually, the program was introduced to reduce the maternal and child death. And since the introduction of this, the arrangement was that we deploy the skilled midwives, but the student, the retired midwives and the graduating students to hard to reach areas and the communities. So, and since the introduction of that program, and we have actually had a lot of changes that came, or benefit that came, and those are there has been an increased access to skilled birth attendants or skilled birth attendant or the midwives in the communities. So when they were deployed, initially the places where you hardly have midwives, they started having them. And because of that, there's also improved maternal care.
Okay.
Those are the reasons why the scheme was set up for. So there was that increased maternal care at those areas, increased antenatal care and all those services. Then there was also an increase in facility-based delivery. Facility-based delivery, a lot of people are coming. Before the introduction, people normally they go to their traditional birth attendants, people that have no skill and this to deliver there. So after the introduction of this program, or immediately at the introduction of this program, a lot of people started patronizing the health facilities or the primary health care centers, even in the villages. Then there's also improved referral system.
Okay.
So when we say referral system and emergency cases, when we say referral, before the introduction of the midwife service scheme, they don't even come to hospital. Even those with complicated pregnancies and labor cases, they don't even come. But if they deliver, when they deliver in the center or they attend the antenatal care, those cases are being picked up by the skilled midwives and referred. Those that they cannot handle at that particular facility. So that was improved. So because of that, a lot of things, and better postnatal and newborn care.
Okay.
So if they deliver at home, there are some services that they don't get. But after the introduction of the primary, the MSS, there is this better care that they receive in the hospital, like immunization, breastfeeding. You encourage them to do all those things. Initially, they don't do them at home. So now that this health education goes to them, those things were increased and they were enjoying themselves with that one. And the introduction of midwifery service scheme has also increased community confidence in public health and facilities they have, because they have all these midwives, skilled midwives attending to them. So, and the rate of death has reduced, and because of that, there is increase in the confidence of the public or the communities to the health facilities they have.
Thank you for enlightening us on that, on the impact of this scheme introduced in 2009. Madam Chingere, can you tell us key challenges currently affecting the performance or sustainability of this MSS scheme, especially in rural or hard-to-reach areas?
Thank you very much, Blessing.
You're welcome.
Quite as my chairman has said, we have recorded a lot of positive changes with the introduction of the midwifery service scheme. In as much as that, we still have challenges that are facing these midwives in the discharge of their work. Yes, especially, these midwives are posted in hard-to-reach areas, rural communities. Sometimes accommodation is a problem where they can stay to carry out what they're supposed to do. And then another challenge is remuneration issue, delay in payment of the midwives, and that make poor motivation to work. Another challenge they face is sometimes, the rural communities, rural areas are like a forgotten area. So there is always a lack of good infrastructure, poor infrastructure of the facilities, and then lack of commodities, essential drugs, which hamper the effective discharge of their duties. And another one is in terms of referral too. These midwives are skilled and they identify where there is problem and to refer on time. The transportation issue, to refer them to the referral center where immediate care can be taken, is always one of the challenges the midwives face at the community. That's what they face, the community, the challenges they are facing at the rural areas.
Okay. So. Oga Jama talked about poor working conditions. So how does it impact the motivation and retention
it makes the motivation low.
Midwives.
At the inception of this midwifery service scheme is a partnership between the government, the local government, and the state government. So the local government are supposed to provide accommodation, but you can see what we have now. Sometimes the accommodation is not even there for these midwives to stay and be comfortable to work. So it makes their morale low. And when you are motivated, you tend to perform better. So that is one of the challenges they are facing. And the insecurity issues. This hard to reach area, there are a lot of insecurity issue. You see sometimes in these rural areas, you hear a lot of kidnapping and the rest, and that makes, you put fear on the midwives that are supposed to work in those facilities. So that makes them not to, put in their best. What they expected to do.
So what security measures could help?
I think, let me just add to that issue of insecurity. When we sit down here in Abuja and we talk of insecurity issues in the communities, you can imagine somebody who is a midwife living in Kuje, you happen to send him to a deeper village, asking the person to go. There is a poor access road to that place. Maybe he has to use a bike to get to that village. And when he is coming to that village, I think he is the only person that will be seen in that village coming in. So that's one, there is no access road, security issue. Even if you give him accommodation in that place, there are chances of kidnapping such a person from that place. And if you get to that place, the security issues we are talking about, we actually, even here in Abuja, look at our nurse who was just killed last week on the 3rd of this month. This is somebody who is working in the town, close from work, and was picked by somebody and they kill and dumped somewhere. So the issue of insecurity, actually, if possible, we have said it even in our letters, we say if possible, all those primary health facilities, there should be a police outpost in those places.
Okay.
And then when we are talking about those people, there must be a police outpost in all the communities, and also there is going to be a communication system that if there is any issue, you can quickly call and get help from there. I want to also talk about the issue of human resource. You mentioned shortage of manpower. You mentioned last year, I think in FCT in particular, they were able to work for how many people? About 87 skilled midwives were sent. But the problem, like she said initially, you want to send this 85. How much do you pay them? You are paying them 80,000 naira. That is where funding comes in. You are paying them 50,000 naira. With this 50,000 naira, when you pay, they deduct tax. By the time they deduct tax, a midwife is going home with 40,000 naira. And imagine that person has to transport himself, feed himself, and do everything. That discourages them from going for that program.
True. And
because of that, if funding will increase, security will improve, and all those things can get there. And then when we talk about human resource, some of them, if they are posted there, they are the only people that will be there. You can imagine you are posting a student, midwife who just graduated to a place, he is going to be the only person that is there. So we urge that recruitment should be done so that even when they come, you will have two people on duty. It's not as if somebody will go there, only single person midwife that will go there and close, and then the facility is closed completely because one person will not do. I've given you statistics here before that we have almost, let me say today, increase it again, that we have over 300 health facilities in FCT, primary healthcare centers in FCT. And out of these primary healthcare facilities, I think we have nothing up to, it's not up to 100 now, nurse midwives that are employed under the primary healthcare facilities. And who is responsible for these people? We don't know. The federal government said primary healthcare under one roof. It is only in FCT that primary healthcare is not under one roof. Even this midwifery service scheme that we are talking about, if you look at it, that scheme was actually made that 3 people will be responsible: the federal government through the primary healthcare, then the state government, and the local government. As we speak now, we don't know who is responsible for what, but I need to appreciate the FCT.
Hold that all. I think we have a caller.
Okay.
Hello. Hello, good evening. What's your name and where are you calling us from?
Because it seems as if they are the people that has been very consistent in their own action. Last year, they've been taking care of 87. They took care of 87. But another thing is, even after graduation or completing their programs, to get other people recruited to replace them, there's also a gap. And that gap creates a lot of issues, a lot of confidence from the community, because before you know it, before the next batch will come, these people might have closed.
I think we have another caller. Hello, good evening. What's your name and where are you calling us from?
Hello.
Yes, I can hear you.
Hello.
Hello, I can hear you. Can you kindly speak up, please? What's your name and where are you calling us from?
Good evening. I'm Joy calling from Abuja.
Joy, thank you for your for calling. What's your question, please?
Okay, yeah. My question is, how can the traditional birth attendants be integrated in the midwife scheme? so they can have proper training
Proper
in the
training.
rural communities. Yes, in the rural community.
Okay, thank you so much for that question, Joy. Did you hear what she said? She said, how can the
traditional-
traditional birth attendants be integrated?
Integrated.
into the- okay, Madam Joy, you heard that. You can answer that
I
before
think
we come back to Oga
it
Jema.
is one of our plan to
Okay.
work with the TBS,
Okay.
traditional birth attendant, because you look at these rural hard to reach areas,
Okay.
they are the ones that are available.
Okay.
So we need to work with them, especially in times of referral. You know, most communities, they have that confidence in the traditional
Birth
birth
attendant,
attendant because
okay.
they are living in the same community. So we need to train them on identification of danger signs
Okay.
and referral to the facilities. So when they identify these women that are pregnant, they refer them to the facility where we have the midwives available, because it has been proven, research has shown that the skilled birth attendant helps to reduce preventable death. So we still need that expert care for these mothers and the newborn. The work of the TBS is to identify these pregnant women, refer them, and then know the danger signs that can occur that can lead to maternal and newborn death early enough.
Okay, so
And
it's just to
then-
identify
yes, and
refer
the
them,
danger signs.
not for them to take delivery, per se.
At least to train them, because sometimes it's not easy to say they will not take delivery. Even
Yes.
if you train them that they will still. So let them know the dangers,
Okay.
the danger signs, what they will see, and they know that this woman needs to be referred.
Okay. You're tuned to the network service of Radio Nigeria. The program is Spark, brought to you by the International Center for Investigative Reporting and supported by the International Budget Partnership. We have been discussing, examining the impact of the midwife service scheme. We'll go on a short break now. When we return, we'll be taking your calls for questions and contributions. Please stay tuned.
To tackle pressing issues in our nation, such as unequal maternal health care services, gender-inclusive agricultural support for small-scale women farmers, access to loans, and much more, the International Center for Investigative Reporting presents Spark 2.2, a 30-minute radio program aimed at igniting discussions on these challenges and preferring solutions to them. Spark 2.2 airs every weekday on different radio stations across Nigeria. Mondays, Federal Radio Corporation of Nigeria, 5 to 5:30 p.m. Tuesdays, Anambra Broadcasting Services, 4 to 4:30 p.m. Wednesdays, Freedom FM Kano and Jigawa, 4 to 4:30 p.m. Thursdays, Prestige FM Mina, 5:30 to 6 p.m. Fridays, Live Radio Ibadan and Sweet FM Abeokuta, 4 to 4:30 p.m. Spark 2.2 is supported by the International Budget Partnership, IBP.
We have been looking at examining the impact of the midwife service scheme. Telephone lines are open for you to make your contribution or ask question. The numbers to call are 0808 828 144 453 or 0915 091 0483. Ogamed, I was meaning to ask about the training gaps that prevent MSS midwives from handling emergencies. You want to talk to us about training gaps?
Let me even say this before I answer your question.
Okay.
You know, like we were saying earlier, if you look at the maternal and child death, Nigeria now is ranking second.
Okay.
In the maternal and child death. And actually there is a total lack of political will from the government on training and retraining of midwives. If you look at it now, the government, or particularly let me say the National Midwifery Council, decided to bring up this midwifery training. And when the indices...
We have another caller. Hello? I think the network glitch. You can continue.
When the indices were getting bad, the National Midwifery Council decided to come up with what we call community midwives.
Okay.
And now the gap we have, they have refused to create a cadre for them. They refused, even the midwives the trained midwives now, with time, I think we are not going to have midwives training any moment from now. That means it's like everybody is running away from the midwifery training because it has not been recognized anywhere much, given much recognition, let me put it that way. It has not been given much recognition. And because of that, everybody is running away. And I think the best thing is for the federal government to take it and understand that this is the only thing that can help reduce the maternal and child death in the rural community. Investing and putting money into midwifery, it is putting money into mothers and also to the children and the future of this country. So there's a need for the federal government to take a deliberate act in funding the midwifery training in this country, and also to create a very good cadre for them so that at least a midwife will be happy with his own profession.
Okay. Madashiri, you wanted to say something?
Yes, I will applaud the government for key into the WHO guideline.
Okay.
We have a basic emergency obstetric care where we train the midwives, even the community health extension workers too. They are being trained on how to respond to emergency, how to care to maternal newborn health in emergency to prevent maternal death and neonatal death. So this basic emergency care is what most of the PSA facilities, the midwives that work in those facilities and the CHUs are being trained to carry out this emergency. But the challenge we have is a funding gap to reach out to all the PSAs. But I can applaud the Health and Human Services Secretariat. They have good collaboration with the partners who had also been assisting to ensure that this training is carried out to the rural facilities, all these underserved communities.
Some persons are of the opinion that MSS deserve more funding.
Yeah.
What's your opinion on that?
Yes,
like
they deserve more. Just like as I was speaking with our colleague, the 50,000 stipend is too poor.
Okay.
We need to see how it can be improved. We have minimum wage now, 70,000.
True.
So I don't see why they should be collecting 50,000. It needs to be improved. And considering where they are, the condition, the area they are being posted to, they need more. Because access to this area is not easy. Just as the chairman has already said, getting to the community, to the hard to reach area, accessibility is not easy, and even communication is a major challenge again. When they're in this rural area, they have emergency that can warrant phone call. You see that the access, internet access, is also poor. It's not easy. So sometimes something you can use a phone call to communicate, you need to come back, you know, to communicate. The communication gap is always there because of the internet, poor internet access to the rural area. So they need more funding. They need to be supported so that they can discharge their duties effectively and efficiently.
Okay. Ogameda, how would you rate MSS in area of antenatal care?
Actually, MSS has been perfectly doing well. If you look at it, rating it is something that I can tell you immediately when the program was introduced, all this, we have improved access to what I have mentioned earlier. If you look at the rating at the antenatal care, honestly, let me say 90%, because with the introduction of this, our indices got improved, if not because later the government decided to draw back its foot on this issue. It has helped really, it has helped in reducing maternal and child death. So I will only say the government, particularly the federal government through the National Primary Health Care Development Agency, has to take its responsibility like the program was introduced initially, that they are going to fund some part, state government is going to fund some part, and then the local government has its own responsibility role to play. And I think the National Primary Health Care has actually withdrawn itself from this program and left only to the state government So I don't think the area councils are even involved in this program.
Okay.
As we speak, the Nursing and Midwifery Council has gone further to introduce what we call community nursing training, and the community nursing training was introduced that the area council or the local government areas should send their own immigrants to school to train them so that they can go back and live in the communities
okay.
and then serve their communities.
Okay.
And the program was embraced at the initial stage, but many of the community midwives that were trained now, they are just there. Nobody employed them. They are just roaming about and nobody employed them. So because of that, we are calling on the state or local government areas to actually recruit those people into the system so that we can reduce the maternal and child death.
Okay, Madam Chair.
I wanted to add to the MSS.
Okay.
Quite all right. The National Primary Care Development Agency, they are involved by engaging the midwife through the Basic Care Provision Fund.
Okay.
They pay their stipends for these midwives to carry out the activity to buttress the effect of the shortage of human resource care attendant in the facilities. So through the National Primary Care Development Agency, we engage midwives that are working in the Basic Care Provision Fund supported facilities.
Okay, so as we round off, what specific action can governments, health stakeholders take to strengthen MSS to ensure it meets its full objective as we round off?
The basic thing here, we know the major issue here is when you talk about funding.
Okay.
By the time you fund whatever we are talking about, give money for it, building the facilities, opening road to rural areas, just like what is happening in Abuja. If you open roads to the communities and put basic amenities in those rural areas, like water, road, lights, and everything that is lacking in the villages, by the time you do that, people will be more happy and the security architecture of those places will be improved. Everybody will be happy. Then for the state government also, they have their own role also to play. They have to pay their own side of the funding, counterpart funding. The local government area and the community also at large need to do something. Then particularly the local government and the communities, they say they should provide accommodation, provide security and everything for that. I said earlier before I run.
Yes, thank you so much. Thank you so much, Madam Chair, for coming. MSS is our lifeline, delivering wins for mothers and babies, but demanding action on funding, security, and infrastructure. Join us next time.
Equipment too.
Equipment, okay. Many thanks to the studio manager, Aliyu Bawa, the producer, Vivian Onowewari, engineer, Jonadab Anyawu, ICT, Jonathan Aina, and the ICR social media team led today by Israel Shushimi and Gubri Abdulaziz. I am Blessed Ebirari.